Welcome to the APAPP podcast. Thanks for tuning in today. We're here actually at the APAPP 2025 conference here in Nashville, Tennessee. My name is Mindy Rivera. I'm a clinical nurse specialist, and I practice in pulmonary hypertension at the Cleveland Clinic. I am actually here today with one of the preeminent experts in the advanced practice care of pulmonary hypertension patients. Take it away.
Thank you, Mindy, for that very kind introduction. My name is Melisa Wilson, and I am a nurse practitioner who's been working in the field of pulmonary hypertension for about 20 years now. I work at Advent Health Orlando, and I'm very excited to be at the second annual Association for Pulmonary Advanced Practice Provider Conference. Thank you.
Great. So for those of you at home who might not know, Melisa is actually giving a wonderful talk to summarize the 7th World Symposium Guidelines in Pulmonary Hypertension Management, which I can't believe it, but we're actually a year out from those guidelines being published, which is kind of crazy. Also kind of crazy that you're summarizing the entire guidelines in 30 minutes, which has got to be like a new land speed record in summary. So for those folks in the budget seats at home who aren't able to attend this year's conference, what are some kind of key takeaways or things that you would like to share from your talk?
Well, Mindy, it's funny you said that because as we prepared for the conference, and I thought, man, it was a year ago that it was in beautiful Barcelona, and we were there for 3 days. And you're right, here we are trying to summarize this in 10 minutes per day, right? 30 minutes. But some of the key takeaways that we had that I really things that stood out to me. One was that we started with the patient perspective. And not only was this something that the organization felt was important, it was important enough that it was front and center. The very opening was by a patient, a very active advocate, strong vocal leader in the PH space, was really shared her story, I should really say, and the story of those living with PH, and how all that we do should really be centered around them in terms of not just that we're helping them make decisions, but having them be involved in the decision making. That really stood out to me as such an important part of the conference. It really set the tone and the expectations. And they said that everything from clinical trials to not just participating in them, but discussing the design of them and what they're looking for. So I thought that was absolutely a dynamic piece of the World Symposium conference. There were some changes that were made to the classification system. So really being a little bit more granular again in how we are breaking down different subgroups within the groupings of the pulmonary hypertension classifications, as well as the treatment algorithm was simplified since the last time they had
simplified and also complicated to some people, right?
Right. It's the same concept of I say pH is rare, and I'm like, is it? It's all I do.
It's all I do every day.
Every day. It doesn't feel rare, right? So you're right. Simplified yet complicated because, as you know, we had more new medication, new pathways come to market, and no longer are we in the days where we had one IV medication and one oral medication. Now we have so many more options, and how do we help make them make sense? And one of the things that really stood out was, that pre-transplant that you anticipate those patients should be on 4 medications.
Right.
That was definitely one of the standout points from that.
I think it's always interesting, we practice at very high volume, very academic centers. And so sometimes I forget that what practices seem kind of commonplace to me at this point are still really getting traction in other areas of the world, in other centers, even in the US. Because to me, it's kind of, okay, the patients going for transplant are most intense and invasive intervention for pulmonary hypertension. Why wouldn't we have them on every drug class? And, hell, let's even invent new drug classes, right? Everything but the kitchen sink to really help these folks. So I think that was a really important update of the guideline. And I think also, too, something that, to me, out of all of the information that came from the World Symposium, probably has gotten the most air time, really, about where new therapies fit in, where we should be utilizing them, what patients we shouldn't be utilizing them in. So, like you said, it used to be back in the day, we had one option, for each category, and everything was kind of smooth and clear cut. But, now the waters are a little muddied, and I'm sure in your clinical practice too, it's, it's kind of, it's great to have more tools in the toolbox, but we're still really kind of learning how to utilize them.
Absolutely. And you couple that with risk stratification and where does that fit and how do you apply risk stratification appropriately and then help that guide your decision making with the patient perspective in mind, right? So focusing on the ease of use as new therapies come around, but also like getting the right medication to the right patient at the right time. So that's why I always say that that's where the art meets the science. And the more skills and experience you have, the easier that complicated yet simplified algorithm looks.
I think this is one space, and at least in pulmonary hypertension management, that AI will not be coming for our jobs anytime soon, right? Because we can put in the hemodynamic criterion, classifications of patients, testing, all that, come out with a risk evaluation score, and still there be some art and humanity in how we apply the guidelines.
Absolutely. And, and even talking about the risk piece of it, a big part of that was really truly emphasizing at the conference that low risk is the key. And so it's not, high risk and stable, intermediate, high risk and stable, intermediate and high and stable. It's low risk. Low risk is our goal. But the key is also who's the right patient and what are those limitations to applying those risk assessment scores or categorization to the right patient and understanding the why behind it. Like I said, AI is not going to be able to figure that out for us. So we're pretty safe right now, I think, in our space. But it definitely had a lot of robust conversation around risk assessment, where we are headed, how we apply it. What did it mean? It's meant to be prognostic. Yeah, because we also use that to literally drive our therapy options for our patients. So the discussion around that was very, very intense. I'm going to put it like that. But what was also neat was this was actually the first year, I believe, that it also had discussion beyond just the European Respiratory Society and Cardiology Society risk assessment tool, but we also had discussion around the risk, reveal risk score as well too. So that was also a great part of the experience being there.
Yeah, I think definitely the reveal risk stratification score is getting a lot more airplay, not just in terms of what we're doing in the United States, but also internationally. And it's been kind of cool to see, U.S.-driven pulmonary hypertension management kind of have a footprint on the world stage. So absolutely.
I think, like you said, the Europeans, because of the way their clinics are designed, tend to have a much more pure type of clinical practice compared to what we see in the U.S. So I agree. It's really important that we have the experiences that we have here where things are just maybe not as clean, so to speak.
We're Americans treating Americans, right?
Yeah, right. You know what I mean? Whatever comorbid conditions that look like was just not as neatly packaged.
Right.
So being able to utilize and talk about the reveal risk score, which had 3,515 patients enrolled in it.
Just a couple.
Just a couple, for PH, that's massive.
For PH study, right. That's amazing.
It's massive.
We may never meet that again.
Right. But it really did help bring home that, it has a place. It has a place and it should be utilized too. And I think that was a really great win in my mind to see that be brought forward in the meeting.
Sure. Absolutely.
And also in the meeting, the other big update what we have is really that we're also not just looking at, we touched on it, new therapies, but as well as new imaging or how imaging could be advanced. And maybe that is where AI comes in to help support us, help make the diagnosis sooner using tools that we use very commonly in these patients.
I think there was a lot of support and evidence behind the use of cardiac MRI imaging in this guideline. And I think that's something that we're going to see even more embedded into our risk stratification and how we manage and assess these patients. As we're learning more that the RV is really in kind of the driver's seat of that patient's long-term survival. So I thought that was an interesting focus as well. Hopefully, I don't know about your center, but sometimes, there's some logistical issues with getting a cardiac MRI every time that you want one in all the patients that you want them in. So, hopefully that's something that takes more of a foothold in clinical practice.
Yeah. And that's where I would really say I would urge our partners who are in technology to come up with things that are more MRI compatible, so we don't have those challenges and barriers with those people on parenteral prostacyclin and sub-Q prostacyclin with their devices.
When you get a call from the imaging nurse, like, hey, the patient's got this attached, what should I do? I don't think people realize how much of a logistical issue that really presents.
Absolutely. So, I think it's, and also when we talk about the RV, also even the echocardiogram and what components of an echocardiogram should also be part of that risk stratification tool was part of that discussion. Mm-hmm. Awesome.
So one of the things that I also noticed, talked about in the guidelines, which I think is something that we've shied away in terms of the pulmonary hypertension community, which is actually something I'm speaking about tomorrow, is the guidelines about pulmonary hypertension management in special populations, including everyone's favorite scary topic of the pregnant PAH patient. So I thought it was the most comprehensive recommendations I've seen using all of the more recent publications to talk about which PH patients it might be feasible for them to carry a pregnancy. So that was kind of, I think, exciting guidelines that we do really need in clinical practice about how we manage those patients, how we, determine which patients might be a candidate. But I think, the data really shows that it still needs to be patients with mild pulmonary hypertension that are really well managed. So, but nice to see that getting some discussion as well, because that's a real issue that we deal with in clinical practice, right? And
that's absolutely right. So we can recommend that this doesn't happen, but reality may be different and different factors, whether it's cultural, personal beliefs, or oopsies. It can happen. So I completely agree with that. And you emphasize the biggest piece of it is that the patient must be closely monitored, not just through the pregnancy and the delivery itself, but even 3 to 6 months later, as those hemodynamics change, that's such an important piece of it. So that's where that expertise care comes in. And this patient should become your best friend during that period of time, them and their baby.
Yeah, no, it's a true reality. I'm sure you've had this clinical experience as well, where patients will show up with newly diagnosed pulmonary hypertension that was, manifested and uncovered through them carrying a pregnancy and now in the postpartum period. So, it's a reality. It's a reality of our lives.
Right.
Other than all of the robust, controversial, animated discussions that usually happen when you get pulmonary hypertension providers in a room. But apart from that, about, hemodynamic guidelines and classifications, was there anything else that you thought was particularly either novel or controversial or anything surprising from these updates?
I would say really no controversies. I've heard in the past things have been a little bit more intense at some of these meetings. So I was waiting for it, but
they calmed down just because you were there. They wanted to be on their best behavior.
And I was looking for a little drama, but it was really it really was more of a report out, the way a lot of things were described as the different task force reported out what their recommendations were for the management of pH. So really nothing controversial. I think what was interesting is at that time, sotatercept had just been approved. So it was March and the meeting was in July. To really talk about where that fits in was such an important part of that emerging therapy conversation and what is there to come in the future with additional clinical trials and new pathways and new agents, and even potentially how new agents will work together in synergy. It's just a huge part of where we are. I'm curious to see what comes. They meet next week, but it's not as a big of a meeting as what this one was last year. But the 8th Symposium, I think, will have maybe have a little bit more flair to add to it now that we've had more experience with the most recent, which really game changer in the space of
Absolutely.
pH.
Absolutely. Yeah, I'll be curious to see by the time we roll around to the 8th World Symposium guidelines, it will kind of be an old hat at using activin signaling inhibitors. So we'll be curious to see how the conversation changes. Is there anything else that you imagine being a kind of prominent role in the next conference, or, strategies or directions you see pH care going in?
Well, I think something that everything, I'm going to go back to kind of like the hemodynamics, right? So, when I started this, and you probably started this too, mean PA pressure greater than 25, right? Wedge less than 15, and a pulmonary vascular resistance of greater than 3 Woods unit.
Which seems wild now, right?
Right now, like we say that, and I'm like, I don't even think I need to bring it up to people anymore, except for the
insurance companies.
And because that's what the medications were improved on, right? So when I'm teaching other APPs around it, I tell them this is what existed. And to see the World Symposium align with the guidelines that also dropped the mean PA pressure to 20, which was previously adopted, but dropping the PVR to less than 2, or greater than 2, for PAH. Let me be that specific around it. Really, I think it still provides a lot of opportunity for us to look at those patients who meet that categorization, who have those mean PA pressures between 21 and 25 or 20 to 25, to understand those patients more. So I think there's more to come in that space, so that we can understand the opportunity to intervene truly sooner. And I think the world is still working really hard to get the awareness of the disease state out there. So how do we use these guidelines to help us find these patients and to drive us to manage and treat these patients and ensure that we are appropriately categorizing them with their diagnosis so that we give them the best chance of survival.
Absolutely. So I know we're kind of early in on the conference for 2025 here at the Association of Pulmonary Advanced Practice Providers. But if you had to give anyone a tidbit or incentive why they really shouldn't miss out on next year's conference in 2026, what would you say?
So I think every year this conference gets bigger and better.
Yeah.
Bigger and better. And the diverse topics, and to be in a space where experts, APPs, are teaching our peers to also become expert APPs. That mentorship, those relationships you build, there's no place else like that, as you're going to get this in specifically the pulmonary space. And, I'm a cardiopulmonary girl. That's how I'm going to put myself.
Me too. I'm cardiology in sheep's clothing.
But that was how I was trained in all of this, was through cardiology. But I love coming to this conference and learning about it because each, as you and I know, everything about pH, every group, every classification is touched by a lung or a heart or rheumatological or immunological. pH is so diverse that anywhere you can go to learn more about these underlying conditions only strengthens our knowledge and our ability to really seek more understanding towards those who have pH, because all of these conditions that we're learning about here has the risk of developing pH too. So I think it's a wonderful place to be, great place to network, and you get to meet wonderful people like Mindy.
I think it's such a great collaboration of different folks from different pulmonary walks and, sleep medicine and critical care and, us folks in pH, in our institutions might not necessarily get the, ability to collaborate or might be not treating multiple diagnoses. So it's such a cool opportunity to learn from other APPs in the pulmonary space. So to me, if you're an APP, this is a conference not to be missed. So
I agree. And it's a great value. The value that what the cost is to attend and the value you get out of it, they don't really match. That doesn't mean we need to raise the price, by the way.
No. But our education budgets also aren't going up anywhere.
Right. So really it's I agree. It's not one you want to miss, and it's one that I definitely recommend people come out to.
Well, thanks so much, Melisa. Thanks for all of your wisdom and expertise in pulmonary hypertension management. And thanks to everyone for listening in. We hope you've learned something, and we hope we'll see you in 2026.
See you then.